I have a professional runner who has an injury going on 2 years. And it's not a painful injury, but when he's running, he's constantly aware of the fact that the left foot favors supination. And so one of his goals is to have normal mechanics of the left foot restored and be able to run without the awareness of those altered mechanics. And so we did a whole body evaluation, and he's very strong. Usually you'll have some inhibition of muscle strength, but his muscle strength is normal in the left foot and ankle musculature. He certainly would have an endurance deficit, which he actually mentions as well. That would make sense. We would expect him to have some balance deficit, and we tested him, and he actually does really well standing on the left foot. And he does, however, the upper body deviates to the left slightly. So one of our goals of treating him will be to resolve that. And of course, you know, it would be appropriate to do much more advanced balance challenge. But for our purpose today, we just did the quick screen there. Although we've been evaluating him for an hour now. So there's so much you can do in an hour, and doing advanced balance stuff was not something we did. But we know that it's affected somewhat, and so we know it has to be treated. So looking at his feet and ankle on both sides, he's very tight in his heel cords. And when I passively test him, I don't quite get to neutral. Now when he actively dorsiflexes, he takes a slightly different route, deviates a little bit medially, and he can get to neutral or perhaps 5 degrees of dorsiflexion. And it's fairly symmetrical on both sides. There's probably a subtle difference, but he's tight on both sides, and I think that treating both sides makes sense. Now he does have greater mobility deficits with passive motion testing on the left lower extremity, but one deficit we did note is that he lacks superior glide of the fibula on the right side. The injured side is the left side. So we definitely want to restore this, because the fibula being it's functioning in its end range of inferior glide, and that's going to favor supination, and it's going to favor plantar flexion, of course, a component of supination. He has greater motion deficits on the left side that we'll show you in just a minute, but I also want to point out that big toe extension is only about 30 degrees, maybe 35, and those are equal on both sides, but I would like to increase that. So now, focusing on the affected side, he also lacks superior glide of this fibula, but he also has a prominent lateral malleolus, and when I try and create movement in that structure, I'm pushing downward with a reasonable amount of force, and there's no movement there. We do the same thing on this side with a reasonable amount of force. There's that motion. There it is. And we take up that slack, and then I can impart a little bit more force, and you feel a spring and a recoil. Do you feel that?
Yes.
Okay. So that's normal functional mechanics, is that with a joint you should be able to take it to an end range, tighten up the soft tissues around it, and then induce a forward spring, and it should also recoil. This is lacking. Same thing at the fibular head. No play going from front to back, and no play going back to front. And I think that when we restore motion down here, I think the pattern in the upper and the superior tib-fib joint will change. The other motion difference is in the midfoot. On his right midfoot, I can pronate that very freely. Navicula feels very free in terms of superior inferior glide, and in terms of moving with the other bones, moving into pronation. On this side, this just feels really tight. Can you feel that?
Yeah.
You feel the difference?
Yeah.
And I'm trying to, flatten that arch. I'm trying to move that midfoot, and it's just not going. Now, the fifth ray had normal mobility. the cuboid is predictably tight, okay? And I'm not getting any joint play going superior, inferior with cuboid. It also has a rotatory component. But I'm not feeling any cuboid motion, but I rather think that when we restore the other motions, including midfoot, I think cuboid will just come along and I think that its motion will be much improved. So I think that covers all except subtalar joint. Let me back it up and talk about, again, his lack of dorsiflexion. I think that we can restore some posterior glide, but more importantly, posterior rotation of the talus. Okay? So in doing that, and if we can improve that motion, increasing dorsiflexion of the ankle, I think the subtalar joint might soften up and give us a little bit more motion down there. Let's have you lie on your stomach with your feet off the edge. Okay, so this is left side, this is the affected side. And on his right side, when I try to evert the ankle, there's a little bit of play, not a lot. So this is calcaneal eversion. On the affected side, there's none at all. So coming back to this side, there's a little bit of play. I think you can see that I can take the slack out of the system, but then I can impart a little force and gain just a little bit more mobility. On this side, the slack's already taken out and I can't get any mobility there. Or if I can, it is so slight. Now I'm going to test what I call external rotation, but the formal terminology is abduction of the calcaneus. So I'm going to rotate the calcaneus towards the left, towards the midline, and the front of the calcaneus, and therefore the foot, should rotate outward. And I'm the cameraman, so I apologize, there's no close-ups, and we're not doing different angles. And I appreciate it's suboptimal, and I appreciate we're dealing with some very small motions that the camera might not be able to pick up, even under ideal circumstances. But I still think there's I think it's a worthwhile conversation about how to evaluate and treat a chronic supinatory pattern, especially in a runner. So I'm going to, you see that play? Mm-hmm. You see that? We can rotate the back of the heel towards the left, and the front of the foot goes outward. But it only goes, what I think is about 5 degrees. Very slight motion. It'd be nice if we could improve that on this side, and I think we can. If I'm wrong, we'll discover that. On the affected side, you see that little bit of play there? I took up the slack there, and now there's no motion. Now I cannot add any additional movement, and the foot was lying perpendicular to the floor, whereas this one went at least 5 degrees laterally. So we have a lack of calcaneal abduction. Now, if we wanted to be really formal, really precise, we would compress the malleoli, which would considerably reduce motion in the ankle, and it would be isolating the subtalar joint of the talus and calcaneus, the top of the calcaneus. There's just no give here at all, none at all when I do that. So this describes what we found with foot and ankle. And we also found an asymmetry in the lower part of his pelvis. And a traditional pelvic sacroiliac screen would not capture the pattern in the pelvis, which I call a left lower wind-swept pelvis. And I already have video up that describes a left lower windswept pelvis, so I'm not going to elaborate much on that. But it is important to screen the joints above And we did screen his knees and we did screen his hips. And when we got to the pelvis, we encountered a lower pelvic asymmetry of both position and of mobility. So we do similar spring testing, passive motion testing in the pelvis, similar to what we've seen here on the foot and ankle. He also has considerable tightness in the right suboccipital region, and he has a reduction in passive accessory motions where the occiput and C1 connect, the occipital-atlantal joint, and reduction in rotation and side glide of the atlas, the C1 vertebrae. And I think that when we improve his mechanics, his mobility in the left foot and ankle, I think that the upper cervical pattern is simply compensatory, and that will either disappear reflexively or that it will be much easier to treat. But I think that we've covered enough territory here, and I'll stop filming and we're going to treat him. It certainly will take me the rest of another hour to go through the treatment. I use very small forces for a sustained period of time. Sometimes I'll use an oscillation, and I'll do at least 30 reps of oscillation. So we will treat these motion restrictions that we've identified, including the pelvis, and we will film the after effect.